the points which are important regarding carcinoma gallbladder is that it is a very disease with very poor prognosis, and generally the outcome depends on the location of the tumor. Okay, if the tumor is present in fundus, then it is generally less, you can say, malignant or less advanced as compared to the tumor present at the neck region. Okay. Also, it depends on the histology whether it is diffuse, infiltrative, or nodular or papillary. Generally, the papillary type of histology is associated with a good prognosis. Okay. And what is the problem in carcinoma gallbladder? Why it is so rapidly progressing as compared to other tumors, and why it is associated with a poor prognosis? As we all know that normally in the which layers the gallbladder is missing. The layers are muscularis mucosa and submucosa. So, any tumor which is present in the epithelium, it can reach to the mucosa early, and that is why there is early lymph nodal spread, early advancement, and generally the patient presents in the advanced or the metastatic stage. Okay, now as we have discussed in the liver that the gallbladder fossa or the gallbladder is present in the is attached to the liver and at the gallbladder fossa, and the gallbladder fossa is belonging to the segment 4b and 5. That is why the tumor which is present on the hepatic side will involve the segment 4b5 early. Okay, so there is a possibility of liver infiltration also, and the gallbladder that is present in the neck region will involve the cystic duct and the CBD. So it can present as jaundice also. So just have a look at the diagram here. This is liver. This is the GB fossa. This is segment 4b and 5. Here there is a gallbladder. If a tumor is present in the fundus region, if the tumor is present at the neck region, there is a high possibility of involvement of CBD leading to a jaundice. It can lead to the involvement of the confluence also, and the portal vein and other hepatic artery structures or the other vascular structures can also be involved. So the neck tumor, GB neck tumor, are associated with comparatively poor prognosis and more unresectable diseases or advanced disease. Whereas fundus tumors are generally better in compared to neck tumors. They are associated with good prognosis and are generally less advanced. There is liver here, segment 4b5 is here, 4b and 5. So whenever we are going for cholecystectomy, we have to remove segment 4b5 along with the gallbladder and along with the lymph nodes which are present along the CBD and along the cystic duct area. Okay, so we cannot perform a normal cholecystectomy in a carcinoma gallbladder. Majority of the cases we have to perform extended cholecystectomy, which depends on the stage of the disease or T stage of the tumor, but in majority of the cases we have to perform extended cholecystectomy. It can present with abdominal pain, it can present with jaundice as well. Okay. Now, overall, what all are the predisposing factors or the etiology of carcinoma gallbladder? Etiology of carcinoma gallbladder. So there are pre-malignant conditions which can lead to development of carcinoma gallbladder. These are choledochal cyst, gallbladder stone more than 3 centimeter, porcelain gallbladder, primary sclerosing cholangitis, adenomatous polyp, and chronic typhoid carrier. Okay, smoking is not a risk factor. This is important. Smoking is not a risk factor. Okay, India and Pakistan are two countries which are having a lot of cases of carcinoma gallbladder, and maximum incidence is seen in India, followed by Pakistan. In India, maximum incidence is seen in UP, followed by Bihar. Okay, now the gallbladder cancer is generally seen in more commonly seen in females who belong to 6 to 7 decade. Majority of the tumors are adenocarcinoma. Few percentage of the tumor are neuroendocrine tumor or the mixed adeno-neuroendocrine tumor, but the most commonly they are seen in females who are 6 to 7 decade older, and most common histology type is adenocarcinoma. Now, the tumor markers for CA gallbladder are CEA and CA19-9. CEA is a non-specific marker. It is raised in other diseases also, and the CA19-9 is more specific to the hepatobiliary type of malignancies. Okay. Now, there are 3 histological types. I have already told you. These are diffuse infiltrative, or sclerosing type. There is nodular type and there is papillary type. As the name are suggesting that diffuse infiltrative is associated with poor prognosis. This papillary type is associated with good prognosis. Okay. But the bad thing is that this diffuse infiltrative is the most common type. Okay. So this diffuse infiltrative is the most common type, and when we see from fundus, body and neck region, most commonly the tumors are seen in fundus, seen in up to 60%. This body tumors are seen in 30%, and neck tumors are seen in 10%. Okay. So majority of the tumors are present in gallbladder fundus, and the most common type is diffuse infiltrative. Most common histological type is adenocarcinoma, and more commonly seen in female patients. Okay. And which liver segments are involved? They are segment 4B and 5. So segment 4B and 5 are the segments which are involved, and they are involved early and they are removed in extended cholecystectomy. Okay. What is the most common spread to the liver segments? It is direct spread. Okay, most common route of spread to the liver segment is the direct spread. And now, majority of the patients with gallbladder cancer have gallstones. but majority of the patients of the having gallstones does not develop a gallbladder cancer. Okay, the percentages are also important, but this point you have to understand. Majority of patients with ulcerative colitis does not develop primary sclerosing cholangitis, but majority of the patients with primary sclerosing cholangitis, they have ulcerative colitis or a long-standing ulcerative colitis. Similarly, majority of patients of carcinoma gallbladder have gallstones. This is in the range of 75% to 98% cases. Okay. Gallstone patients overall 0.3 to 3% cases develop carcinoma gallbladder. Generally 1 to 2% of these cases can develop gallbladder cancer. And if the size of stone more than 3 centimeter, this increases the risk of development of carcinoma gallbladder. Okay. Now, the next point is, what is the clinical feature? The patient generally presents with a long-standing history of abdominal pain with a sudden change in the character of pain, and initially the pain used to be type of a biliary colic, it comes and goes, but now there is a continuous dull aching pain in the abdomen. Okay. Along with that, it is associated with anorexia, weight loss. Few patients having gallbladder neck tumor can present with jaundice, and few patients in very advanced stage, it can lead to a involvement of duodenum or colon and can lead to development of gastric outlet obstruction or colonic obstruction. Okay, so generally the clinical features are long-standing history of biliary colic, but now pain increases in severity and duration, and continuous dull aching pain is there. There is a sudden change in character of pain associated with anorexia and weight loss. Okay. Other than that, if there is a neck tumor, can present as jaundice, late stages can present as gastric outlet obstruction, colonic obstruction. Gastric outlet obstruction occurs because of duodenal involvement. Colonic obstruction occurs because of colonic involvement. Okay. Now, how to diagnose carcinoma gallbladder? Diagnosis. Generally, any patient with having gallbladder type pain, we initially go for ultrasound. So, the first investigation is ultrasound. And the investigation of choice is CT scan. Generally, what we see on CT scan is that there is a gallbladder wall thickening with presence of a definite mass in the gallbladder wall, which is enhancing. There is presence of liver infiltration and associated with lymph nodes in the along the CBD. Okay, so gallbladder mass, liver infiltration, lymph nodes. After that, we'll have to first stage the disease to decide the treatment. The staging is AJCC 8th staging. They have recently revised the staging, and there are a lot of changes in between the AJCC 7th and 8th. So the one thing that I have already told you is that majority of the patients, oh, the gallbladder does not have the muscularis mucosa as well as the submucosa. Okay, so initially there will be a tumor in the epithelial layer or the lamina propria, then it will reach straight away to the muscle layer. Okay, so this is important to understand, and there is no muscularis mucosa and submucosa. So I'll write here that muscularis mucosa and submucosa is absent in gallbladder. This is very important to remember. So you can see here that in T0 there is no evidence of primary tumor. T1A, the tumor involves lamina propria. But in T1B, the tumor directly involves muscle layer. Okay, or the muscularis propria. This is muscularis propria. Okay. Now, in T2A, the tumor invades perimuscular connective tissue on the peritoneal side. Now, what is the peritoneal side and what is the hepatic side? Suppose this is liver and this is gallbladder here. Tumor here is the peritoneal side. Tumor on the opposite side here is the hepatic side. Okay. So, if the tumor is present on the peritoneal side, it is only present on the peritoneal side, but there is no serosal involvement right now, and the liver is also not involved. Just the tumor is present on the serosal side. With the nature of tumor being on the this is on the peritoneal side. So if the tumor is present on the peritoneal side, it is T2A. But if the tumor is present on the hepatic side, it will become T2B. Okay. Right now there is no liver involvement. Okay, there is no liver involvement, but the tumor is present on the hepatic side is T2B. Now the T3 is tumor is perforating through the serosa and is directly involving the liver or one adjacent organ. Okay, and or one adjacent organ is important to remember. This can be stomach, duodenum, colon, pancreas, omentum, or bile duct. Okay, these are the structures which will not make it metastatic disease. This is local involvement. Okay, so a question comes to you: direct involvement of stomach in carcinoma gallbladder is T3. Okay, direct involvement of carcinoma gallbladder to liver as well as stomach or duodenum is also T3. So you can see here clearly it is mentioned that T3 is directly invading the liver and or. Okay, so it can also involve one organ structure apart from liver. Okay, this T4 is when it involves the main portal vein, hepatic artery, or two or more extra hepatic organs or structure. If there is involvement of two or more extra hepatic organs, liver along with duodenum and colon. Okay, this means T4. This is important. Now, coming to the nodal, if there is no regional lymph node metastasis, it is N0. If there is presence of 1 to 3 lymph nodes, it is N1. 4 or more lymph nodes, it is N2. Okay, and metastatic is if there is no metastasis, it is M0. If there is a distant metastasis, it is M1. Okay, now coming on to the stage of the disease. Okay, this is the TNM classification, stage of the disease. This 1A is T1A, 1B is T1B, 2A is T2A, 2B is T2B. So this is similar to that, and 3A is T3A. Okay, if this 3B is T1 to 3 but N1. So if there is N1, it is 3B. Okay, this is important to remember. Then if there is presence of T4, then it is 4A, and if there is presence of N2, or M1, okay, T, Ne, and Ne, then it is 4B. I will again write the important points here. Okay, this way you can remember. Presence of N1, just like it was there in Ca colon also, presence of node, it becomes stage 3. Here also, presence of node, it becomes stage 3, but it becomes stage 3B. Okay, not the stage 3A. N2, it becomes stage 4, that to 4B. Okay, this is important. Stage N2 is stage 4B. So they might give you that in the final histopathology, 4 lymph nodes out of 10 were positive. What is the stage? So the stage is stage 4. Okay, which stage? Stage 4B. Okay, and another important thing that we usually practice, N2 or M1 generally have a similar prognosis in carcinoma gallbladder. So even if there is a distant node, even if there is a node present in the interaortocable region, we will consider it as a metastatic node, distant node, and this distant node is having almost a similar prognosis as compared to a liver metastasis, distant liver metastasis, or some pulmonary metastasis. Almost the prognosis is similar. So the N2 or M1, they have almost similar prognosis, and they are categorized as 4B, and this T4 is stage 4A. Okay, this is important to remember. Now we are going for treatment for stage 1A or T1A. Okay, that is, the tumor is involving only the lamina propria. It is not involving the muscle, it is not involving the serosa. Only lab cholecystectomy is sufficient. Okay, for stage 1B to 3B, we will go for extended cholecystectomy. In extended cholecystectomy, we will remove segment 4B5 along with gallbladder, tail cystic duct, and pericholedochal lymph nodes. Okay, we will do remove gallbladder with segment 4B5 with pericholedochal or lymph nodes along cystic duct, periportal lymph nodes. Okay, this is for extended cholecystectomy. Okay, now for stage 4A and 4B. Generally for 4A and 4B, it is better to give chemotherapy first. For stage 4A, we can, currently there is no literature in favor of neoadjuvant chemotherapy. There are trials which are being conducted. Right now, the treatment of choice is extended hepatectomy with or without multivisceral resection. If there are other organ structures which are involved, we can remove those organ structures also, and then we can go for adjuvant chemotherapy after the surgery. And stage 4B, that is N2 disease or metastatic disease, we should give a palliative chemotherapy. Now another question. Suppose we have performed a cholecystectomy for gallstone. After surgery, the final histopathology after 1 week came out to be carcinoma gallbladder involving lamina propria. Next treatment will be, so the next treatment in this case will be to wait and watch, because cholecystectomy is sufficient for tumor that is T1A. Okay, so next step will be wait and watch. But if HPE after 1 week came out to be T1B, then the treatment will be, next treatment will be, we will first do a CT scan, and then if there is no metastatic disease, we will go for extended cholecystectomy. Why extended cholecystectomy? Because the gallbladder bed, that is segment 4B5, and the lymph nodes are not removed in the cholecystectomy. That is why, to complete the staging and to remove any portion of the tumor if it is left inside, we will have to perform a cholecystectomy. If it is T1B or T2 or T3, we will go for extended cholecystectomy. Okay. And while performing extended cholecystectomy, we will also perform the port site excision. I have already told you the lap chole port sites. We will do a full thickness excision of those ports, because there is a possibility that while removing the gallbladder, the tumor cells might have spilled into the port site, and there is a chance of developing a recurrence there also. So we also perform a port site excision. Okay. It does not improve the prognosis. The port site excision does not improve the prognosis, but improves the staging of the disease. Okay.